Really, for me, it started way back when I was in nursing school, which, shall I say, was 1970. And I was exposed to the work of Kubler-Ross. And that work really resonated with me around good death and around death and dying. I got to this because when I was in college, I was involved in the care of a dear, dear friend. She had been my high school English teacher, and she had a recurrence of breast cancer as a very young woman, early 30s. And she was a very visionary and brave person, and she didn't want to be in the hospital. She wanted to be at home. She wanted to, she happened to live with her older mother. She wanted to be at home and spend as much time as she could there. This was in the mid-70s, and we barely had heard of hospice in the United States. We didn't have it there in Tucson, Arizona, where I lived.
I wanted to actually work with HIV and AIDS patients. This was in the 1990s, and asked for a field placement in the area, and I actually was placed at a hospice as a hospice social work intern, and I absolutely loved that work. I felt like doing hospice social work was a real gift to me, to be able to sit with people through this really tough and emotional journey was a blessing that I got to learn from.
Her physician would write to the insurance company and say she needs nursing care at home. She's dying of breast cancer. And the insurance company would write back in a very official letter, she is not in the hospital, therefore it is not medically necessary. And the physician would write back and say, she doesn't need to be in the hospital, there's nothing the hospital is going to do for her, but she does need nursing care. She's very sick, she's dying. So it was in that small group of friends who we kind of created hospice. We didn't know that's what we were doing. There were nurses who were attending to her. And it was with her that I saw the power of that last chapter in someone's life.
I loved being able to get to know people in their homes, to hear their life stories, and to also recognize that oftentimes when a person is dying, it can be very hard for patients and for family members to talk about that. You know, we live in a world oftentimes that doesn't allow for a lot of sadness, and yet this is something really big. And to be able to sit with people and help hold their grief was just something that was really meaningful to me in that work.
A story that I would like to tell that sort of started me on this journey was when I was an early career nephrologist. I can recall I was making rounds in the dialysis center, and one of my patients, I think he was 58 years old, he had underlying kidney disease from membranous glomerulonephritis. He had no other chronic medical problems. He was likely the most healthy patient I had in the dialysis center. Said to me one fall, "Doc, this is no life. I want to stop dialysis." And I said to him, "Well, you know, you can't do that. If you do that, you'll die." And he said, "Well, you know, this is just no life." It was only then that I realized that he had depression from seasonal affective disorder, and that sort of keyed me into the fact that I need to pay attention to patients' symptoms. And we now know that when you attend to patients' symptoms and successfully treat their symptoms, you improve their quality of life. So as a nephrologist, as a palliative care physician, one of the most satisfying things is to make interventions that improve our patients' quality of life.
So as I went through my nursing career, I've had several experiences that really spoke to me about this, personal experiences. In particular, one patient many years ago that I still really carry with me in my heart. And the very first professional presentation that I did around supportive care for kidney patients to a group of nurses, I dedicated it to that patient because I felt like in that experience, in that story, that she deserves so much better in the way of supportive care than what she received.